Welcome to the Deep Dive, the show that takes your stack of sources and really digs into them to pull out the most important bits of knowledge and insight.
That's the goal.
Today, we're plunging into a truly fascinating, but yeah, often challenging area of human health. It's something most of us probably don't think about much, until something goes wrong.
That's usually the way.
Did you know that the veins in your legs, they're constantly fighting gravity, just battling away to get blood back to your heart? And that tiny, really delicate valves are absolutely crucial to this huge everyday task.
It's quite the system.
Or that the lymphatic system, which often gets overlooked, is just as vital. It prevents chronic swelling, keeps your body's fluids balanced. It's key.
Absolutely essential, yeah.
That's right. So today we're taking a deep dive into the complex and critical world of venous and lymphatic diseases. We're talking about things from, common conditions like varicose veins, all the way to more serious ones like deep vein thrombosis, DVT, or even chronic lymphedema. These unsung heroes of your circulatory system are absolutely essential for your body's overall health and well-being.
Exactly. We've got a really comprehensive stack of your sources on these topics, and our mission, like always, is to extract those vital insights. We want to offer you a shortcut, really, to being well-informed.
Yeah, hopefully with some surprising facts, maybe a bit of humor to keep things moving.
Right. Think of it as a guided tour through these intricate circulatory and lymphatic networks. We want to help you understand not just what these conditions are, but maybe more importantly, why they matter to you and what's actually being done about them in modern medicine.
Okay, let's unpack this then. We talk a lot about arteries, right? Those high-pressure highways carrying oxygenated blood away from the heart. But veins, they're arguably just as crucial. They manage the whole return trip. So what exactly are veins and why are they so vital to how our bodies function?
That's a great place to start because veins are really dynamic and often, like you said, underestimated. Their main job, their primary function, is getting that low nutrient deoxygenated blood back to the heart.
The return journey.
The return journey. And in our legs especially, that's a constant uphill battle against gravity. Yeah. It really is. But they're also a critical reservoir. They act like a flexible storage system, to stop too much blood just pooling in one spot.
So like a holding tank, almost.
Sort of, yeah. A low pressure, high volume return highway with flexible capacity. And this blood flow, it depends on a really intricate balance of factors. Gravity, obviously.
Right.
But also the proper functioning of those clever one-way venous valves we mentioned. Then there's the rhythm of our heart and breathing, our overall blood volume, and this is really important, the calf muscle and feet pumps. They literally squeeze the blood back up.
Wow. So any change in that balance?
Any change in that delicate balance, that can lead to significant venous problems.
So they're definitely not just passive tubes then. They're actively managed, incredibly flexible. What about their structure? How do they differ physically from arteries? Does that support these unique jobs?
Oh, absolutely. Structurally, veins are quite distinct. They're typically thin-walled, remarkably stretchy, or distensible is the technical term, and highly collapsible.
Collapsible?
Yeah, unlike arteries which need to withstand high pressure. This unique architecture is specifically designed for their dual functions.
Yeah.
Getting blood back efficiently and acting as that big blood reservoir.
Okay.
If we look closer at their layers, the innermost layer, it's lined with this special non-clotting surface. It's called endothelium.
Unclotting, that sounds important.
It's vital. And what's fascinating here is that this lining actively produces relaxing factors, things like nitric oxide. These basically keep the blood flowing smoothly, stop platelets sticking, prevent clots from forming right there on the vein wall. Then moving outward, you've got the middle layer, the media. This has rings of elastic tissue and smooth muscle. This is what gives veins their incredible ability to expand, stretch out dramatically with only minimal changes in pressure. That's their reservoir function in action.
Makes sense.
And then on the outside, the adventitia, that provides structural support. It's this amazing stretchiness that lets a vein's diameter expand several times its normal size when it's really full compared to when it's relaxed.
That's incredible. A dynamic, anti-clotting, super flexible tube. But okay, how do these seemingly simple tubes make sure blood flows one way, especially against gravity in our legs? I mean, it feels like it would just pool, just fall back down.
That's where the venous valves come in. They are truly ingenious little structures. Unidirectional flow, especially in the main long veins of your body, the axial veins, it's achieved by multiple venous valves, acting like these perfect little one-way gates.
Big gates, okay.
Now, it's important to note, some major veins don't have valves. like the biggest one bringing blood back from your lower body, the inferior vena cava, or the veins inside your head, they're valveless.
Interesting.
But in the arms and legs, where gravity's a constant fight, valves are more numerous the further down you go. So more valves near your feet than near your torso.
That makes sense.
And each valve is pretty delicate. It's made of two thin, leaflet-like cusps, just connective tissue covered by that smooth lining. And their closing mechanism is precise. They snap shut instantly in response to any blood trying to flow backwards, cephalid to caudal flow if it's moving fast enough. This prevents that backflow and keeps blood moving towards the heart.
Like perfectly timed traffic cops for blood flow.
Exactly. Only letting the blood go one way. No U-turns allowed, especially not because of gravity.
Okay, so we've got these incredible valved tubes. Now let's put a map out. Where are they? Starting with the lower extremities, the legs. How are those veins laid out?
Right, the lower extremity veins. They're usually divided into three main systems. You've got the superficial, the deep, and the perforating veins.
Okay, superficial, depth, perforating.
The superficial venous system is the one just under the skin. It's mostly made up of two major veins. The great saphenous vein, or GSV.
Heard of that one?
Yeah, it's quite famous, relatively speaking.
Yeah.
And the small saphenous vein, the SSV, plus all their smaller branches. The GSV is really long. It starts on the top of your foot, runs up the inner side of your leg and thigh, and eventually connects into a deep vein up near the groin.
Mm-hmm.
And an important point, running alongside the GSV is the saphenous nerve, which gives you feeling on the inner part of your leg and ankle.
Good to know. And the SSV.
The SSV, the small one, starts on the outside of your foot and runs up the back of your calf. Usually it dives deeper behind the knee to join the popliteal vein, which is a deep vein. But its connection point can actually vary quite a bit from person to person.
Ah, anatomical variation.
Exactly. And it also has a nerve companion, the sural nerve, providing sensation around the outer ankle bone.
Okay, superficial covered. And the deep veins. I'm guessing they're, deeper. And maybe run with the arteries.
Precisely. The deep veins in the limbs generally follow the path of the major arteries. Often they run in pairs, especially in the lower leg.
Paired veins?
Yeah, you'll have paired veins running alongside the main arteries, like the tibial arteries. These then join up behind the knee to form the single popliteal vein.
Okay.
Then, as you go over into the thigh, the popliteal vein continues and becomes the femoral vein. Higher up, the femoral vein joins another deep vein, the deep femoral, to form the common femoral vein, right near the groin crease. And that then becomes the external iliac vein as it goes up into the pelvis.
It's like a river system getting bigger as it flows up.
That's a great analogy. And then you have the perforator veins. These are critical connectors. Think of them as little tunnels.
Tunnels?
Yeah, they pierce through the deep tissue layers, the fascia, connecting the superficial system with the deep system. They allow blood to flow from superficial to deep.
Ah.
Clinically, some perforators on the inner lower leg are really important. In conditions like venous insufficiency, these can become leaky or incompetent, meaning their valves fail. This plays a big role in chronic swelling and skin problems, especially those stubborn venous ulcers around the ankle.
Right, the gator area ulcers you mentioned.
Exactly. And finally, there's one more unique structure. The venous sinuses. These are found within the muscles, particularly the big calf muscles like the soleus and gastrocnemius.
What's special about them?
They're thin-walled, large, and interestingly, they don't have valves inside them. They act like little reservoirs within the muscle, storing quite a bit of blood. And every time your calf muscle contracts, like when you walk, it squeezes this stored blood out efficiently into the main deep veins, giving it a powerful pushback towards the heart. It's like a built-in booster pump in your legs.
Wow, our bodies are pretty clever. So what's fascinating here is thinking about the arms. Are there similar setups? What are the key differences in the upper extremities?
Yeah, the upper extremity veins also have deep and superficial systems, but the layout is a bit different. The deep veins start small in the hand, form arches, and then empty into paired veins that closely follow the main arteries in your forearm, the radial and ulnar veins.
Venae comitantes, right, the accompanying vein.
Exactly, venae comitantes. These paired veins then merge near the elbow to become the brachial veins in the upper arm, which eventually combine to form the axillary vein in your armpit.
Got it. And the superficial arm veins.
For the superficial veins in the arm, the two main players are the cephalic and the basilic veins. The cephalic vein starts on the thumb side of your wrist, runs up the outer side of your forearm and upper arm, and eventually dives deep near your shoulder to empty into the axillary vein.
Okay.
The basilic vein runs up the inner side, the pinky finger side, of your forearm. Past the elbow, It dives deeper and joins up with those deep brachial veins to also become the axillary vein. And that vein you often see used for blood draws right in the crook of your elbow.
Yeah, the median cubital.
Usually the median antecubital, yeah. That connects the cephalic and basilic veins right there on the front surface of the elbow. It's a common access point.
Okay. And how does it all get back to the heart from there?
So as these veins move towards the center of the body, the axillary vein becomes the subclavian vein as it passes under the collarbone. Then the subclavian vein joins with the internal jugular vein, which is draining your head and neck, to form the brachiocephalic vein. You have one on the left and one on the right. These two large brachiocephalic veins then merge together to form the superior vena cava, the SVC, which is the main vein draining the upper body, and that empties directly into the top right chamber of the heart, the right atrium.
So similar principles, superficial, deep valves, but different geography for the arms.
Precisely. The layout is adapted for the unique anatomy and how we use our arms.
All right, all that detail about the structure and pathways, it really highlights how complex these systems are. So let's say someone suspects something's off with their veins. Maybe their legs feel heavy or they see some changes. What's the very first step a doctor takes?
Well, the evaluation always starts with a really detailed conversation about your health history and then a thorough physical examination. That's the foundation.
Okay.
The doctor will be listening closely, trying to identify any risk factors you might have for both acute problems, like a sudden blood clot, DVT, and also for chronic issues, like that long-term venous insufficiency, CVI.
Yeah.
These risk factors are pretty broad. They include things like getting older, having a personal history of blood clots before, any current or past cancer, recent trauma, or maybe a spinal cord injury, being hospitalized and not moving much, obesity, being pregnant or recently postpartum, even using things like oral contraceptives or hormone replacement therapy.
A whole lot of factors.
A lot. And having pre-existing varicose veins or known conditions that make your blood clot more easily, those definitely increase the risk too.
Okay, so history first, then the physical exam. What are they looking for?
During the physical exam, problems with your veins are often, but importantly, not always, associated with things you can see or feel. For instance, just looking at superficial veins, there's huge variation.
How so?
Well, a very lean, athletic person might have veins that look quite large and prominent when they're standing, even if they're perfectly healthy. But in someone who's obese, those same veins might be much harder to see. So it's not just about seeing veins, it's interpreting what you see in context.
Gotcha.
We look for specific things that suggest superficial vein abnormalities, like are the veins twisted or bulging? Are there little distended veins that look like spider webs? We call that corona phlebiticata. Or maybe tiny intradermal ones, spider angiomata. Is there warmth, redness, tenderness along a vein? That could suggest superficial thrombophlebitis, a clot with inflammation.
Right.
But, and this is a critical limitation, the deep veins, the really big important ones, you can't directly assess those just by looking or feeling. Any problems within the deep system can only be inferred indirectly from other signs found during the exam. #, unpacking chronic venous insufficiency, CVI.
Okay, let's talk about CVI, chronic venous insufficiency. It sounds persistent, like a long-term problem. What does it actually do to the body, and why is it so damaging?
CVI, it can definitely lead to some very characteristic persistent changes in the skin and the tissues underneath in the affected limb. It primarily happens because those one-way venous valves we talked about become incompetent. They just stop closing properly.
Leaky valves.
Leaky valves, exactly. Or it can be due to a blockage, an obstruction in the vein, or often it's a bit of both. Most cases involve some degree of reflux, that backward flow of blood. And severe CVI often reflects both reflux and obstruction working together.
And the target is the skin.
Right. It's crucial to understand that while the problem starts in the veins, the ultimate target organ of CVI is the skin. And the exact ways this leads to skin damage are still not perfectly understood, but we know the basics.
What does a leg with CVI typically look like or feel like?
Typically, a leg affected by CVI will be swollen, edematous. And that swelling usually gets worse through the day, maybe a bit better overnight. The leg might also feel kind of hardened, indurated, and you'll often see brownish pigmentation. Eczema, dermatitis, itchy, dry skin is common too.
Why does that happen?
Well, it seems to be linked to excessive linkage of fluid and proteins from the tiny capillaries in the skin. This leakage might limit nutrient exchange. Also, immune cells, white blood cells, can get trapped in the skin's microcirculation. This leads to congestion, inflammation, and eventually tissue damage, and in the worst cases, ulceration.
So it's a cascade of problems.
It really is. Over the long term, this impaired nutrition and chronic inflammation can cause scarring and hardening of the tissue that's lipodermatosclerosis. And that characteristic brownish color that's from iron deposits, hemosiderin, left behind from old red blood cells that have leaked out.
And the ulcers?
With long-standing high pressure in the veins, venous hypertension, ulcers can develop. The most common spot, as we mentioned, is about an inch or so above the inner ankle bone in that gaiter region. These can be incredibly difficult to heal.
This raises an important question. Thinking historically again, how did doctors evaluate these conditions before we had things like ultrasound widely available? Was there a classic test for CVI back then?
Yes, absolutely. There is a historically significant clinical test called Trendelenburg's test. Now, it's rarely used today because we have much more objective methods, but it was designed to figure out if leaky valves were present and which system, superficial, deep, or perforator, had the problem.
How did it work?
It had two parts. First, the patient lies down, leg up, to empty the veins. Then the doctor presses firmly on the main superficial vein in the groin, the GSV, maybe uses a tourniquet. While still pressing, the patient stands up. The doctor watches the superficial veins in the leg to see how they fill.
Right, okay.
If they fill up suddenly while the pressure is still on the GSV, it suggests the leaky valves are in the deep veins, or the connecting perforator veins. Then the doctor releases the pressure on the GSV and watches again. If the veins fill rapidly, then it points to leaky valves in the GSV itself.
And if they fill slowly?
A slow, gradual filling, just from normal arterial inflow, that was considered a negative result, meaning no significant reflux. But the big limitation was subjectivity. How rapid is rapid? It was open to interpretation.
Right, not very precise.
Exactly. Which is why it's been largely replaced by the more objective, reliable tests we get from the Vasco lab today.
So if Trendelenburg's test is mostly history, what is the gold standard now for checking out the venous system? How do doctors get the full picture reliably?
Today, the absolute cornerstone, the gold standard for non-invasive evaluation is duplex ultrasonography, or DUS, especially when it's boosted with color flow imaging. It's really been a game changer.
Okay, DUS. How does it work for different problems?
Well, for deep vein thrombosis, DVT, it's the standard for finding clots in the leg veins below the groin. It's got incredibly high sensitivity and specificity, near 100% really, in patients who have symptoms.
Yeah.
It's also the go-to for looking at clots in the arm veins. And for chronic venous insufficiency, CVI, it's super useful because it can directly show us leaky valves, that reflux, and also identify any blockages or obstructions.
So it shows structure and function.
Exactly. DUS combines real-time ultrasound imaging, that's the B mode, the grayscale picture, with Doppler technology, which measures blood flow. We do maneuvers like gently squeezing the leg or having the patient take deep breaths to see how flow changes. And the color flow imaging adds that visual map of blood movement. It lets us non-invasively see the vein anatomy, spot clots or narrowings, and observe the actual characteristics of the blood flow.
What's considered normal flow then?
In a patient lying flat, normal flow in the leg veins usually changes with breathing. It slows down a bit when you inhale because pressure increases in your abdomen and speeds up when you exhale. When you're upright, those calf muscle contractions in the valve are key for pushing blood up.
And for DVT detection, you mentioned compression.
Yes, for detecting DVT in the bigger veins, from the groin down to the knee, the primary method is demonstrating the lack of compressibility of the vein. We just gently press down with the ultrasound probe. Normally the vein walls should flatten completely, they should co-opt. If they don't flatten, it means there's something inside holding them open, a thrombus, a clot.
Makes sense.
For the smaller veins in the calf, compression can be tricky. So there, we often rely more on seeing abnormalities in the color flow imaging, like no color filling the vein where it should. Other signs suggesting DVT on DUS include seeing no spontaneous flow, no color filling, losing that normal respiratory variation, or seeing the vein look swollen or distended. But that lack of compressibility is really the key diagnostic finding for the bigger veins.
Were there other non-invasive tests before DUS became dominant?
Yeah, historically, before ultrasound was so advanced, we used techniques based on plethysmography, like impedance plethysmography, IPG, which measured changes in electrical resistance related to blood volume changes in the leg. But it was much less accurate than DUS, especially for clots in the calf, so it's rarely used now.
Okay, so DUS is king for non-invasive, but are there still situations where doctors need to actually go inside the body, use invasive methods to get the full picture?
Yes, there are, although much less often now thanks to how good DUS is. Invasive procedures are much more selective. Venography, for example, is still technically considered the gold standard, especially for research studies comparing new techniques.
How does that work?
It involves placing a small catheter, usually in a vein on top of the foot, injecting a radiopaque contrast dye, the kind that shows up on x-rays, and then taking radiographs. If the dye doesn't fill the deep veins properly, maybe diverting into the superficial ones, or if you see clear filling defects spots where the dye can't go because there's a clot that's a positive result, a totally normal venogram pretty much rules out a DVT.
But it has downsides.
Big downsides. It's invasive, can be painful, there's a risk of causing a clot or bleeding at the injection site, and there are the usual risks associated with contrast dye, like allergic reactions or kidney problems, though rare with newer dyes. Because of these risks and the invasiveness, it's really not used routinely in day-to-day clinical practice anymore.
Okay. Any other invasive tools?
There's intravascular ultrasound, or IVUS. This is typically used as an add-on during procedures, like stenting a vein. Access is usually through the main vein in the groin. A tiny ultrasound probe on a catheter is put inside the vein.
Inside the vein, wow.
Yeah, it gives incredibly detailed pictures of the vein wall and any blockages. It's particularly good for looking at the big iliac veins deep in the pelvis. Seems to be more sensitive than even venography for spotting narrowings or compressions there.
And what about those older invasive tests for CVI you mentioned, AVP?
Right, ambulatory venous pressure, AVP, and venous reflex time, VRT. These were early diagnostic studies specifically for CVI. They involved inserting a needle or catheter into a foot vein, connecting it to a pressure monitor, and having the patient do exercises like tiptoeing.
Measuring pressure during movement.
Exactly. The pressure would drop during exercise and then rise back up. The lowest pressure reached was the AVP, and the time it took to get back near the starting pressure was the VRT. A very short VRT meant leaky valves, significant reflux. High AVP indicated high pressure in the veins, venous hypertension, which correlated strongly with the severity of CVI and the risk of ulcers.
But DUS replaced these too.
Largely, yes. Because while AVP and VRT gave us valuable information about overall venous function and pressure, they couldn't pinpoint where the reflux was happening or assess the calf pump function specifically. DOS gives us much more detailed, localized information non-invasively.
Okay, let's shift focus to venous thromboembolism, VTE. That includes both DVT, the clots in the limbs, and PE, pulmonary embolism, clots in the lungs. This sounds like a really major health issue. Just how common is it, and what puts someone at risk?
It is indeed a significant health problem. And, despite a lot more awareness and better preventative measures, VTE remains a really important and often preventable source of serious illness, morbidity, and even mortality, especially for surgical patients.
How common are we talking?
Well, in the general population, the incidence is around 100 cases per 100,000 people per year. But importantly, about 20%, 1 in 5, diagnoses are made within 3 months of having some kind of surgical procedure.
Wow.
And when patients do have symptoms, about a third present, first with a PE, the lung clot, and 2/3 with a DVT in a limb. If you look at the estimates for the U.S., it could be over 600,000 cases a year. It's a major, major U.S. health problem.
And the outcomes?
Sadly, death occurs in about 6% of DVT cases and 12% of PE cases within just 1 month of diagnosis. Now, not all those deaths are directly caused by the VTE itself. Sometimes it's the underlying condition that led to it.
Right.
That's still a stark number. And beyond the immediate risk, having a VTE puts patients at higher risk for it happening again. And for those long-term consequences we touched on, like pulmonary hypertension, which affects about 4% long-term, and post-thrombotic syndrome, the chronic leg problems, which can impact up to 30% of people.
That's a huge number. So what causes these clots? What are the risk factors?
To understand the risk factors, we often go back to something called Virchow's triad. It was described way back in 1862 by Rudolf Virchow. It outlines 3 broad conditions that contribute to VTE formation.
Okay, what are they?
First, there's stasis of blood flow. Basically, blood not moving well, maybe from being immobile after surgery or during a long flight.
Makes sense.
Second is endothelial damage. That's injury to the inner lining of the blood vessel itself, maybe from trauma, surgery, or even inflammation. And third is hypercoagulability. This means the blood itself has an increased tendency to clot, maybe due to genetic factors or certain medical conditions like cancer or medications like estrogen.
Stasis, damage, and clotty blood.
You got it. And what's really crucial here is that these factors don't just add up linearly. They seem to multiply the risk. Having even 2 seemingly minor risk factors can exponentially increase your danger. It seems like hypercoagulability might be the most important factor when VTE happens seemingly out of the blue, what we call spontaneous or idiopathic VTE, whereas stasis and endothelial damage probably play a bigger role when there's a clear trigger, a provoked VTE, like after surgery or trauma. Often, more than one of these factors is present.
Can you give some specific examples of risk factors?
Sure. Common acquired risk factors include older age, definitely over 40, being hospitalized or immobile, using hormone replacement or oral contraceptives, pregnancy in the period right after birth, having had a VTE before, having cancer, major surgery, obesity, certain kidney diseases, trauma or spinal cord injury, even long-haul travel over 6 hours. Varicose veins themselves are a risk factor.
Okay.
Then there are heritable factors, things you're born with. Being male is actually a slight risk factor. Specific gene mutations like factor V Leiden or the prothrombin gene variant. Deficiencies in natural anticoagulant proteins like protein C, protein S, or antithrombin.
Genetic predispositions.
Exactly. And sometimes there's a mix of inherited and acquired causes. Other things like traditional cardiovascular risk factors, obesity, high blood pressure, diabetes seem to play a role too. We even see racial differences. VTE is more common in whites and African Americans than in Asians and Native Americans.
Any anatomical issues?
Yes, definitely. We mentioned May-Thurner syndrome earlier, where the right iliac artery compresses the left iliac vein in the pelvis, making clots more likely on the left side. And any kind of external compression on major veins, maybe from a tumor or cyst, can also cause problems. Because many VTEs are linked to predictable risk factors, especially around surgery, risk assessment is now a really standard part of preoperative care.
It sounds like, and you mentioned this before, symptoms aren't always reliable for DVT. So how do doctors really know if a patient has one, especially if the signs can be, well, misleading or even absent?
You're absolutely right to keep stressing that. Clinical symptoms are notoriously unreliable. Early on, when the DVT is just starting, maybe in those calf muscle sinuses or behind a valve cusp, it might cause no symptoms at all. Even a large clot can be present without obvious signs, especially if the person isn't walking around much.
So you can't just rely on leg pain or swelling.
Definitely not. Because leg pain and swelling are so nonspecific, they can be caused by 100 different things. Large studies have consistently shown that DVT is actually confirmed in 50% or even fewer of the cases where it's clinically suspected based on symptoms alone.
Less than half. Wow.
Yeah, that's why objective studies are absolutely required to either confirm or confidently rule out VTE. You just can't guess.
But sometimes the symptoms do get worse, right? You mentioned those severe conditions.
Yes. As a DVT grows and blocks off the major deep veins, the main drainage pipes, clinical symptoms often worsen. If it blocks those main channels but largely spares the smaller collateral or bypass veins, you can get that condition called phlegmasia cerulea dolens.
Blue leg, right.
Literally, painful blue edema, yeah. It's characterized by intense pain, deep pitting edema, swelling that leaves an indent when pressed, and a scary cyanotic bluish discoloration of the limb.
And if it gets even worse.
If the clot then extends into those collateral veins too, blocking almost all outflow, it causes massive fluid buildup, even more significant edema. That's phlegmasia alba dolens, painful white edema. If the leg is extremely painful, hugely swollen, and looks pale or white. This is often because the swelling is so intense, it's actually compressing the arteries and reducing blood flow into the limb.
That sounds incredibly dangerous.
Both are extremely serious emergencies. They can be complicated by venous gangrene, tissue death, and may ultimately require amputation to save the patient's life.
Okay, so given the unreliable symptoms and the potential severity, how do we diagnose it definitively? Back to the lab and imaging.
Exactly. Back to objective testing. And as we've established, duplex ultrasound, DUS, is the workhorse. It's the most commonly performed test for suspected DVT below the groin with that excellent sensitivity and specificity in symptomatic patients.
Remind us again what DUS shows for DVT.
Okay, so DUS combines that B-mode imaging, the picture, with Doppler to see flow. The primary diagnostic method, especially for the bigger veins from the common femoral down through the popliteal behind the knee, is demonstrating the lack of compressibility. You press with the probe, a normal vein flattens, a clotted vein doesn't.
The clot holds it open.
Precisely. In the calf veins, where compression is tougher, we look more closely at color flow imaging for abnormalities, like lack of color filling. Other signs, again, include lack of spontaneous flow, loss of that normal change with breathing, seeing the vein distended. But non-compressibility is the #1 sign for those proximal veins.
What about those older tests? IPG, FUT phonography.
IPG, impedance plethysmography, was the main non-invasive method before DUS really took off, but it's much less accurate and rarely used now. FUT, the fibrinogen uptake test, using radioactive fibrinogen, that's really just a historical research tool now, very limited use. And phonography, the X-ray with dye, remains the gold standard for comparison in studies. But because it's invasive, carries risks, and DUS is so good, it's not used routinely for clinical diagnosis anymore. DUS is really the frontline test.
Okay, so let's say DUS confirms a DVT, or maybe imaging confirms a PE. What happens next? What's the immediate game plan, and what about the long term? Sounds like you need to act fast.
Absolutely. Swift action is critical. If the clinical suspicion for VTE is high, doctors should often start antithrombotic therapy, blood thinners right away, sometimes even before the diagnosis is 100% confirmed by imaging.
Why the urgency?
The goals are twofold and immediate. First, prevent death and serious illness from a pulmonary embolism, stop the clot from traveling or getting bigger. Second, prevent the long-term complications of post-thrombotic syndrome, PTS, in the affected limb.
Makes sense. So what are the treatment options?
It's really a multi-pronged approach, tailored to the patient. The mainstays include antithrombotic therapy, the blood thinners. Then there's the possibility of placing a temporary or permanent vena cava filter. In some cases, especially severe ones, catheter-directed or systemic thrombolytic therapy, clot busting, might be used. And in very rare, extreme situations, operative thrombectomy, surgically removing the clot.
Okay, let's start with the blood thinners. What are the main types?
Right, antithrombotic therapy. The initial treatment, often started in the hospital, usually involves injectable medications. The classic is unfractionated heparin, or UFH. It's typically given as a continuous IV drip.
Heparin, okay. How does it work?
It works by binding to a natural anticoagulant protein in your blood called antithrombin, and basically supercharging its activity, making it thousands of times more effective blocking key clotting factors like thrombin and factor XA.
Needs monitoring, though.
Yes, UFH requires close monitoring with blood tests, usually the APTT test, every 6 hours or so, to make sure the dose is therapeutic but not dangerously high. The main complication is bleeding, of course. And there's that rare but serious side effect called heparin-induced thrombocytopenia, or HIT.
HIT, what's that?
It's a reaction where the body makes antibodies against heparin complexed with a platelet protein. Paradoxically, this can cause platelet counts to plummet and trigger massive new clotting. It's an emergency if it happens. Platelet counts have to be monitored closely when someone's on heparin.
Okay. Are there alternatives to UFH?
Yes, a major advance was the development of low molecular weight heparins, or LMWHs, like enoxaparin. These are derived from UFH but are smaller molecules.
What's the advantage?
Several advantages. They have much more predictable absorption and elimination after being injected under the skin, usually just once or twice a day. For most patients, they don't require routine laboratory monitoring, which is a huge plus.
Big convenience factor.
Huge. They also seem to cause less bleeding and have a significantly lower risk of causing HIT compared to UFH. A major benefit is that stable patients with DVT can often be treated with LMWH injections at home, avoiding hospitalization.
So LMWH is often preferred now.
In many situations, yes, especially for outpatient treatment. There's also fondaparinux, which is a synthetic drug that specifically targets factor XA. It's also given as a once-daily injection and doesn't usually need monitoring. It seems comparable to LMWH in effectiveness and safety.
You mentioned HIT. What if someone develops that or can't take heparin-based drugs?
That's where direct thrombin inhibitors, or DTIs, come in. Drugs like argatrobin, given IV, or dabigatran, an oral pill. They work by directly blocking thrombin, independent of antithrombin. They're mainly reserved for patients who have confirmed HIT or are highly suspected of having it.
And the newer oral drugs, DOACs.
Right, the direct oral anticoagulants, or DOACs. These has really revolutionized long-term VTE treatment and prevention for many patients. They come in two main classes. Direct factor XA inhibitors, like rivaroxaban, apixaban, edoxaban, and the direct thrombin inhibitor we just mentioned, dabigatran.
What's the big appeal?
The key advantage is that they're taken orally as pills and generally do not require routine blood test monitoring to adjust the dose. They have fixed dosing regimens. This is a massive improvement in convenience and quality of life compared to warfarin. They've shown comparable effectiveness to traditional therapy in large trials.
Any limitations?
They might not be suitable for patients with severe kidney or liver impairment, as that's how they're cleared from the body. Data is still limited in very obese patients. And until recently, reversal agents weren't available for all of them, though that's changing rapidly. Itarazumab reverses dabigatran, and indexinate alpha can reverse the factor VIII inhibitors in emergencies.
Okay. What about the old standby, warfarin? Still used.
Oh yes, warfarin, brand name Coumadin is common, is still a mainstay of long-term VTE therapy for many patients. It's a vitamin K antagonist, meaning it interferes with the liver's production of several key clotting factors, 2, 7, 9XX, and also natural anticoagulants, protein CNS.
Takes time to work, right?
Yes, it takes several days to reach its full effect because it has to deplete the existing functional clotting factors. That's why it's always started along with an initial fast-acting injectable anticoagulant, like heparin or LMWH, which is continued for at least 5 days and until the warfarin level is therapeutic.
It needs careful monitoring.
Absolutely. Warfarin requires regular blood tests measuring the INR, International Normalized Ratio, to ensure the dose is just right, usually aiming for an INR between 2.0 and 3.0. The dose needed can vary hugely between people and can be affected by diet, especially vitamin K intake, other medications, illness, and liver function.
How long do people stay on warfarin?
The duration varies greatly. It depends on whether the VTE was provoked, for example, by surgery, or unprovoked, if it's a first or recurrent event, the location of the clot, and other factors like cancer or underlying clotting disorders. For a first provoked DVT, maybe 3 months. For unprovoked VTE, the risk of recurrence is much higher, so extended or even indefinite therapy is often recommended. For VTE related to cancer, LMWH is often preferred over warfarin for long-term treatment.
Main risk is bleeding.
Bleeding is the primary complication, and the risk increases with higher INR levels. The good news is warfarin's effects can be reversed relatively quickly with vitamin K, or more urgently with plasma or concentrated clotting factors if needed. There's also a rare but serious side effect called warfarin-induced skin necrosis.
Okay, that covers the blood thinners. Now here's where it gets really interesting. Can we actually dissolve these dangerous clots? What's the cutting edge there?
Yes, this is the area of thrombolytic therapy, often called clot busters. For patients who have extensive acute DVT, particularly involving the large iliofemoral veins in the thigh and pelvis, actively dissolving the clot can be very beneficial.
How does it work?
Thrombolytic agents, drugs like Eltaplas, TPA, Retaplas, Tenectaplas work by converting a natural substance in your blood, plasminogen, into its active form, plasmin. Plasmin is an enzyme that directly breaks down fibrin, which is the protein mesh that forms the structure of a blood clot, so it literally dissolves the clot.
Were these given systemically before?
Historically, yes. Older trials gave thrombolytics intravenously, letting them circulate throughout the body. While this did show more clot lysis and potentially less long-term PTS compared to just anticoagulation, it also came with a significantly higher risk of serious bleeding complications elsewhere in the body.
So a better way was needed.
Exactly. That led to the development of catheter-directed thrombolysis, or CDT. The goal here is to deliver the clot-busting drug directly into the thrombus, maximizing its effect locally while minimizing the amount of drug circulating systemically, hopefully reducing bleeding risk.
How is that done?
It's usually done in an interventional radiology suite, or cath lab. A catheter is inserted, often through a vein in the back of the knee or sometimes from the groin or neck, and guided using imaging right into the clotted vein segment. Special catheters with multiple side holes are often used to infuse the lead and leak agent along the length of the clot.
Any other techniques used with CDT?
Yes, sometimes it's combined with mechanical methods to physically break up the clot first. This is called pharmacomechanical thrombolysis. Devices like the angiojet use high-speed saline jets to macerate the clot. This can speed up the process. Patients are usually also on heparin during the procedure.
Does CDT actually work better? What did the studies show?
The evidence has evolved. An earlier large randomized trial showed that for acute iliofemoral DVT, CDT significantly improved vein patency, how open the vein was, and led to about a 15% absolute reduction in post-thrombotic syndrome at 2 years compared to anticoagulation alone. That's quite significant. You'd only need to treat about 7 patients with CDT to prevent 1 case of PTS.
That sounds promising.
It was. However, a more recent, very large trial called the ATTRACT trial looked at patients with DVT in the femoral, popliteal, or iliac veins. Overall, it found no difference in the frequency of any PTS between the group getting pharmacomechanical CDT plus anticoagulation versus anticoagulation alone.
Oh, so no benefit.
Well, here's the nuance. While the overall rate of PTS was similar, the ATTRACT trial did find that patients treated with CDT were significantly less likely to develop moderate to severe PTS. So it seemed to reduce the severity of the long-term problems, even if not preventing them entirely. There was no difference in quality of life scores.
What about bleeding risk with CDT?
The ATTRACTOR trial did show an increased risk of bleeding with CDT, about 1.7% major bleeding versus 0.3% with anticoagulation alone. Importantly, though, there were no fatal or intracranial bleeds in either group related to the treatment.
So where does that leave CDT now?
Based on these major trials, the current thinking and guidelines generally support the selective use of CDT, perhaps pharmacomechanical CDT, primarily for younger, otherwise healthy patients with acute, extensive iliofemoral DVT, where the potential benefit of preventing severe PTS might outweigh the increased bleeding risk. For most other DVTs, standard anticoagulation alone is a recommended approach.
Are there people who absolutely shouldn't get thrombolytics?
Yes, there are definite contraindications. Things like having had a stroke or significant head trauma recently, brain surgery, a known brain tumor, active internal bleeding, a known bleeding disorder, or suspected aortic dissection. Serious bleeding away from the access site is uncommon, and brain bleeds are rare. But bleeding at the catheter insertion site is the most common complication.
Okay, now what if a patient absolutely cannot take blood thinners? Maybe they have active bleeding or super high risk. Or what if they keep getting clots despite being on blood thinners? Are there other options to prevent that deadly PE?
Yes, that's precisely the situation where inferior vena cava filters, or IVC filters, are considered. These are small, umbrella-like or cone-like devices.
Like a tiny net.
Kinda, yeah. Designed to be placed inside the inferior vena cava, that main vein returning blood from the lower body. Their job is to physically trap or filter large blood clots traveling up from the legs before they can reach the lungs and cause a PE. They allow blood to flow through, but catch the dangerous emboli.
How are they placed?
It used to be a surgical procedure years ago, but now they're almost always placed percutaneously, meaning through a small puncture, usually in the femoral vein in the groin or the internal jugular vein in the neck. It's done using imaging guidance, like fluoroscopy, X-ray, or sometimes ultrasound. It's much less invasive now.
So who gets an IVC filter?
The main indications are patients with acute VTE who have an absolute contraindication to anticoagulation, like active, uncontrollable bleeding. Patients who have significant bleeding complication while on anticoagulation therapy for a VTE. Or patients who develop recurrent DVT or PE despite being on adequate doses of anticoagulants. Sometimes they're used in patients with severe pulmonary hypertension who couldn't tolerate even a small PE.
If someone gets a filter, do they still need blood thinners if possible?
Yes, that's a crucial point. If the patient can safely receive anticoagulation, it should still be given, usually for the standard duration based on their VTE. The filter prevents PE, but it doesn't treat the existing DVT in the leg, nor does it prevent new clots from forming. So anticoagulation is still key if it's safe. Clinicians should always reassess if anticoagulation can be started later if it was initially contraindicated.
Do IVC filters improve survival? And what are the downsides?
This is important. Routine IVC filter placement has not been shown to improve early or late survival in patients with proximal DVT, while studies show they do decrease the rate of PE.
Which is the goal.
Right. But importantly, there is a consistently shown increased rate of recurrent DVT in patients who have IVC filters placed. So you trade a lower risk of PE for a higher risk of leg clots.
What about complications from the filter itself?
There are potential complications. Acutely, things like bleeding or clotting at the insertion site or misplacement of the filter. Long-term complications can include the filter itself getting clotted off, IVC thrombosis, causing DVT, the filter breaking, migrating out of position, or even eroding through the wall of the vena cava. Fatal complications are rare, but they happen.
Filters can be removed now, right? Temporary ones.
Yes, many filters are now designed to be potentially removable or retrievable. The idea is to use them for patients with a temporarily high risk of PE, and then take them out once that risk passes or anticoagulation can be safely started. They can potentially be removed percutaneously for up to several months after placement, provided they haven't become embedded or trapped a large clot.
Is removal always done?
Unfortunately, no. This is a major issue. Many filters intended to be temporary end up becoming permanent because patients are lost to follow-up or removal isn't attempted. And once they're left in long-term, all those potential late complications come into play. The FDA has issued warnings urging removal as soon as they're no longer needed, typically within about 1 to 2 months. Older embedded filters might even require complex laser-assisted or open surgical removal.
So what's the bottom line on filters from major guidelines?
Currently, major guidelines like those from the American College of Chest Physicians, ACCP, recommend IVC filters only if a proximal DVT, like in the thigh or pelvis, is present, and anticoagulation therapy is contraindicated. They are generally not recommended for primary prophylaxis, meaning just putting one in to prevent clots in a high-risk patient who doesn't already have one.
Okay, that makes sense. Now, for the most severe life-threatening clots, the ones causing phlegmasia or maybe massive PE, what surgical options are on the table? Is surgery ever used to remove clots?
Yes, in very specific, usually critical situations. Operative venous thrombectomy, surgically removing the clot, is generally reserved for patients with acute iliofemoral DVT, those big clots in the thigh pelvis, who are actually worsening despite anticoagulation, or those who present with phlegmasia ceruleodolens with impending venous gangrene, where the limb is immediately threatened.
How is that surgery done?
If phlegmasia is present, often a fasciotomy is done first to relieve the massive pressure in the leg compartments. Then, for the thrombectomy itself, the surgeon makes an incision, a venotomy, into the common femoral vein in the groin. A special balloon catheter, like a Fogarty catheter, is gently passed through the clot up towards the heart, the balloon is inflated, and then it's pulled back, hopefully extracting the thrombus. This might be repeated several times.
What about clots lower down?
Clots further down in the leg might be removed by manually compressing the leg from the foot upwards, maybe using a tight elastic wrap to milk the clot out. If the clot in the femoral vein is old and stuck, sometimes the vein has to be ligated, tied off. If the clot extends way up into the IVC, a bigger abdominal operation might be needed to open the IVC and remove it directly.
How do they ensure it stays open afterwards?
An X-ray with dye, a venogram, is often done during the surgery to check for any remaining clot or underlying narrowing. If there's a narrowing, say in the iliac vein, they might do balloon angioplasty and place a stent right then and there. To help maintain flow and prevent reclotting, often a temporary connection, an arteriovenous fistula is created between a nearby artery and vein to increase flow through the treated segment.
And post-op?
Patients get heparin for several days, then transition to long-term warfarin, usually for at least 6 months. Compression stockings are essential.
What are the outcomes and risks?
Risks include PE during or after the procedure, bleeding, infection. Death is rare but possible. Long-term studies suggest that in limbs where thrombectomy is successful, valve function can be preserved reasonably well, and over 90% of patients might have minimal or no symptoms of post-thrombotic syndrome long-term, which is a major potential benefit compared to just anticoagulation for these severe cases. But early failures of the thrombectomy can occur.
And what about surgically removing clots from the lungs, pulmonary embolectomy?
The surgical pulmonary embolectomy is really only indicated in rare emergency situations, usually for patients with absolutely massive PE causing shock or cardiac arrest, who have contraindications to thrombolytic therapy. It's a major open heart operation done on cardiopulmonary bypass. While survival rates have improved, mortality is still significant, maybe 20–40%.
Are there catheter options for PE too?
Yes. There are percutaneous catheter-based techniques being used more now for PE. These involve either mechanically fragmenting the clot in the pulmonary artery or using suction devices to remove it, often followed by infusing clot busters directly into the remaining clot via the catheter. Small studies show some success, but significant risks remain.
Given how serious VTE can be and how common it is, especially around surgery, what are the strategies for preventing it in the first place? Prophylaxis seems key.
Prevention, VTE prophylaxis, is absolutely paramount. We know patients undergoing major surgery without any preventative measures have a really significant risk of developing DVT. And as we've discussed, tragically, an estimated 1/3 of the perhaps 150,000 to 200,000 VTE-related deaths each year in the U.S. occur following surgery.
That's staggering.
It is. So the goal of prophylaxis is clearly to reduce this VTE-associated mortality and morbidity. And again, because the first sign might be a fatal PE, and clinical evaluation to catch DVT beforehand is unreliable, prevention is the best strategy.
What methods are effective?
Effective methods usually involve one or more approaches, either pharmacologic medications or mechanical. It's important to note that aspirin alone is generally considered insufficient for moderate or high-risk VTE prevention.
What are the pharmacologic options?
Low-dose unfractionated heparin, LDUH, low molecular weight heparin, LMWH, at prophylactic doses, synthetic drugs like fondaparinux, and sometimes vitamin K antagonists like warfarin, though less common for initial prophylaxis. Newer oral anticoagulants are also being used more.
And mechanical methods.
These include intermittent pneumatic compression, IPC devices, those sleeves that inflate around the legs, and graduated compression stockings.
How do doctors decide who gets what?
There are detailed clinical practice guidelines like the ACCP guidelines that help stratify patients based on their individual VTE risk level, their risk of bleeding from anticoagulants, and also patient preferences.
How does risk stratification work, say, for non-orthopedic surgery?
The risk depends on many things. The type of surgery, type of anesthesia, how long it lasts, plus patient factors like age, cancer, prior VTE, obesity, infection. Risk assessment models, like the Rogers score or the Caprini score, are increasingly used before surgery. These scores help categorize patients into risk levels very low, low, moderate, high.
And the recommendations follow the risk level.
Exactly. Very low risk might just need early walking. Low risk might get mechanical prophylaxis like IPC. Moderate risk usually gets LMWH, LDUH, or mechanical prophylaxis. High risk typically gets more potent pharmacologic prophylaxis like LMWH or fondaparinux, often combined with mechanical methods. Patients at high risk of bleeding would get mechanical methods initially.
How long does prophylaxis continue?
Usually until the patient is discharged and mobile. But for certain very high-risk patients, like those undergoing major cancer surgery, extended prophylaxis for 4 weeks or even longer might be recommended after they go home.
How effective are these preventative drugs?
LDUH and LMWH have been shown to reduce the risk of VTE by about 60–70%. LMWH has the advantage of once-daily dosing and a lower risk of HIT antibodies. Fondaparinux has shown similar effectiveness to LMWH in major abdominal surgery.
What about using IVC filters for prophylaxis?
This has been suggested for some very specific high-risk groups, like severe trauma patients or bariatric surgery patients who absolutely cannot receive anticoagulants. Some studies showed low PE rates with filters in trauma patients. However, fatal PEs can still occur, and there are the long-term filter complications like IVC thrombosis and DVT.
So not generally recommended for prevention.
Correct. The ACCP guidelines currently recommend IVC filters only if a proximal DVT is already present and anticoagulation is contraindicated. They are not recommended for primary prophylaxis. If removable filters are used for temporary high risk, meticulous follow-up to ensure removal is absolutely critical.
Now, shifting gears slightly, what's fascinating here is how something that might sound like just a minor irritation, like superficial vein thrombophlebitis, can sometimes be a red flag, maybe pointing to something much more serious going on systemically.
That's a very astute point.
Yeah?
Superficial vein thrombophlebitis, SVT, is basically inflammation and clotting in a vein right under the skin. Yes, it most commonly happens in existing varicose veins, but it can occur in normal superficial veins too.
And the red flag part.
That comes in with a condition called thrombophlebitis migrans. This is when SVT keeps recurring, popping up in different locations in normal superficial veins. When that happens, it can indeed be a significant warning sign. It might signify an underlying hidden cancer somewhere in the body, or perhaps a systemic issue like a blood disorder or a collagen vascular disease.
Important connection. Does SVT happen for other reasons too?
Oh yes, frequently it's a complication of having an indwelling 5E catheter, sometimes related to the medication injected, sometimes just the catheter itself. For instance, arm vein thrombosis, often SVT in the cephalic vein, has been reported in a significant number of patients with PICC lines.
Can it get infected?
Yes, that's suppurative SVT. An infected clot in a superficial vein, often related to a catheter. This can be serious and may lead to generalized sepsis, a bloodstream infection.
What are the typical signs of SVT?
Usually redness, warmth, and tenderness along the course of the affected vein. You can often feel a firm, tender cord or lump under the skin. If it's suppurative, you might also have fever and a high white blood cell count.
How is it diagnosed? And do you need to worry about DVT with it?
Diagnosis is usually clinical, but duplex ultrasound, DUS, should always be performed. Why? To confirm the diagnosis, see how extensive it is, and crucially to determine if there's any associated deep vein thrombosis, DVT.
How often is DVT found with SVT?
It varies, but concomitant lower extremity DVT has been found in anywhere from 5% up to 40% of patients presenting with SVT. The risk seems highest when the SVT involves the main superficial vein, the GSV, and is very close, like within 1 centimeter, to where it joins the deep system, the saphenofemoral junction.
So follow-up is needed?
Yes, for SVT near that junction, but without initial deep vein involvement, a follow-up DUS in about 5–7 days is often recommended because studies show 10–20% can progress into the deep system within that first week.
How is SVT treated then? Sounds like it varies.
It's quite variable, yeah, depending on the location, extent, and whether DVT is present. Reviews suggest that both LMWHs and NSAIDs, non-steroidal anti-inflammatory drugs, can help reduce the extension or recurrence of SVT. One large trial found that fondaparinux significantly reduced the risk of developing VTE in patients with SVT, though the overall VTE rate was low. Topical treatments can help local symptoms.
So it's individualized?
Very much so. For SVT that's not near the deep vein junction, simple measures like compression and anti-inflammatory meds might be enough. If it's suppurative, infected, antibiotics and removing any catheters are absolutely mandatory. Sometimes the infected vein segment needs to be surgically excised.
And if it's close to the deep system?
For SVT extending close to that saphenofemoral junction, treatment aims to prevent the clot propagating into the deep veins. Options include anticoagulation therapy for about 6 weeks, or surgically ligating, tying off the GSV right at the junction. Both seem about equally effective.
We tend to focus a lot on leg clots, understandably, but what about clots forming in the arms? How common is that and what causes it?
That's a good question. Clots in the major veins of the arm, like the axillary or subclavian veins, we call this axillary subclavian venous thrombosis, or ASVT. It does happen, and it has 2 main forms. Primary ASVT is the less common form. It occurs seemingly without a clear initial cause. But these patients often report activities involving prolonged, repetitive, strenuous arm motion. Think baseball pitchers, swimmers, sometimes weightlifters. This repetitive motion is thought to damage the subclavian vein, usually where it gets squeezed between the collarbone and the first rib. This is also known as venous thoracic outlet syndrome, or effort thrombosis, or Paget-Schroeder syndrome.
Effort thrombosis makes sense. What's the other form?
Secondary ASVT is much more common. Here, there's usually an easily identified cause, most often an indwelling central venous catheter, like for chemo or long-term antibiotics, or sometimes a hypercoagulable state. In fact, over 30% of patients with those tunneled subclavian vein access devices can develop ASVT.
What are the symptoms?
Patients might be asymptomatic, or they can present with varying degrees of arm swelling, tenderness, pain, and sometimes prominent visible superficial veins across the shoulder and chest.
Diagnosis. Still DUS.
DOS is usually the first step and can often confirm the diagnosis. However, visualization can sometimes be limited up near the collarbone, and extensive collateral veins can sometimes mask the clot, leading to false negatives. So, if clinical suspicion is high but DUS is negative or unclear, venography, the X-ray with dye, is often recommended.
And treatment.
Anticoagulation therapy should be started as soon as ASVT is diagnosed, mainly to prevent PE. Yes, arm clots can embolize too, though maybe less often than leg clots, and also to decrease symptoms.
What about clot busting for arm clots?
For primary ASVT, especially in young active patients presenting acutely with symptoms, CDT catheter-directed thrombolysis is often considered. The goal is to dissolve the clot quickly to minimize long-term arm swelling and dysfunction. Post-thrombotic syndrome can happen in the arm too. This is often done via a catheter placed in an arm vein, like the basilic vein.
Any procedures afterwards?
Yes. After successful thrombolysis, a follow-up venogram is done. If there's an underlying anatomical problem causing the vein compression, like in venous thoracic outlet syndrome, procedures like removing the first rib or neck muscle resection might be considered to prevent recurrence. Balloon angioplasty of any residual narrowing might also be done. Major guidelines recommend the same duration of anticoagulation after thrombolysis as for those treated with anticoagulation alone.
Let's talk about clots in even more unusual and frankly scary places like the abdomen. How serious is mesenteric vein thrombosis, or MVT?
MVT, a clot in the veins draining the intestines, is indeed a very serious condition. It accounts for about 5–15% of all cases of acute mesenteric ischemia where the bowel isn't getting enough blood flow. And unfortunately, mortality rates can be very high, approaching 50%.
What are the symptoms? Are they obvious?
That's part of the problem. The symptoms are often quite nonspecific initially. Patients usually present with abdominal pain, often diffuse, and distension or bloating. Nausea, vomiting, and diarrhea are common too.
Oh.
Crucially, peritoneal signs, things like severe tenderness when the abdomen is touched, rigidity suggesting intestinal infarction or perforation, are present in fewer than half of patients at presentation. This can delay diagnosis.
Who gets MVT? Any risk factors?
It's more common in patients who have underlying hypercoagulable states, conditions making blood clot easily, malignancy, or cirrhosis of the liver. It can also occur rarely as a complication of laparoscopic surgery.
How is it diagnosed then if symptoms are vague?
Nowadays, most cases are diagnosed using contrast-enhanced CT scanning or sometimes MRI of the abdomen, typically done when evaluating someone for abdominal pain. These scans are very accurate, with sensitivity and specificity approaching 100%. Ultrasound can also be used sometimes.
Treatment. Is it always surgery?
No, actually most patients can be treated non-operatively initially. Treatment starts with aggressive fluid resuscitation, heparin anticoagulation to prevent the clot from getting worse, and bowel rest, nothing by mouth. Once the patient stabilizes clinically, oral intake can be carefully started, and they transition to oral anticoagulation, usually for 3-6 months, or potentially indefinitely depending on the underlying cause.
When is surgery needed?
Urgent surgery, a laparotomy, is indicated if the patient has those peritoneal signs suggesting bowel infarction. Broad-spectrum antibiotics are given. During surgery, the surgeon looks for signs of bowel damage. Often the mesentery and bowel wall looks swollen and bluish. If segments of bowel are clearly non-viable, they have to be resected. Sometimes the surgeon isn't sure about viability and plans a second look operation 24 or 48 hours later to reassess. The goal is always to preserve as much viable bowel as possible.
All right, let's switch to something many people recognize, maybe see on themselves or family members. Varicose veins. What are they really beyond just being visible, and do they pose actual health risks?
That's a great question, because varicose veins are incredibly common, present in at least 10% of the general population, maybe more. They're essentially veins, usually superficial ones, that have become dilated, enlarged, stretched out, and tortuous or twisted. You often see them bulging under the skin. Along with these, people might have telangiectasias, those tiny spider veins, or slightly larger, fine reticular varicosities.
What causes them? Is it genetic?
There's definitely a strong genetic component. A family history is a big risk factor. Other risk factors include obesity, being female, likely due to hormonal influences, pregnancy, occupations involving prolonged standing, and inactivity.
Are all varicose veins the same?
We usually classify them into two types. Primary varicose veins are thought to result from an intrinsic abnormality or weakness in the vein wall itself. Secondary varicose veins, on the other hand, develop as a result of underlying problems in the deep veins or maybe incompetent perforating veins, leading to high pressure backing up into the superficial system.
What symptoms do people typically have? Is it just cosmetic?
While the unsightly appearance is often the main complaint, many people experience symptoms. These can include aching, a feeling of heaviness or fullness in the legs, itching, pruritus, and legs that tire easily. These symptoms characteristically worsen with prolonged standing or sitting and feel better when the legs are elevated above the heart level. A mild amount of ankle swelling is often present too.
Can they lead to more serious problems?
Yes, over time, more severe signs and complications can develop. These include thrombophlebitis, clotting and inflammation within the varicose vein, hyperpigmentation, darkening of the skin, lipodermatosclerosis, that hardening and inflammation of the skin and fat, venous ulceration, though usually related to deeper insufficiency, and sometimes bleeding, which can be quite brisk if an attenuated, thin-walled vein cluster gets bumped.
So how are they treated? Is it always surgery?
Not at all. Conservative management is always the first step, and an important component. This primarily involves the use of elastic compression stockings.
Stockings again.
Yes, they provide external support to the veins, help reduce symptoms, and may slow progression. They come in various compression strengths, like 20-30 millimeters G, 30-40 millimeters G, and lengths, knee-high, thigh-high, waist-high, and should ideally cover the symptomatic varices. For many patients, good quality, properly fitted compression provides sufficient symptom relief.
When is more intervention needed?
Interventional management is usually warranted when symptoms worsen despite compression therapy, or if they're simply not relieved by it, or if the patient develops more severe complications like lipodermatosclerosis or a venous ulcer. And randomized trials have clearly shown that interventional treatment significantly improves quality of life compared to just conservative measures for symptomatic varicose veins.
What are the main interventions?
There are several options, often used in combination. Injection sclerotherapy is one. This involves injecting a special solution directly into the varicose vein or spider vein.
What does the solution do?
It essentially acts as an irritant, damaging the inner lining of the vein, causing inflammation and scarring that closes the vein off. Common agents include hypertonic saline, sodium tetradicylosulfate, and polidocanol. The concentration used depends on the size of the vessel being treated.
What happens after the injection?
Elastic bandages are usually wrapped tightly around the leg immediately after injection and worn continuously for several days. This helps compress the inflamed vein walls together and prevent blood from getting trapped inside and forming a clot. After the bandages come off, compression stockings should be worn for at least a couple of weeks.
Are there risks with sclerotherapy?
Yes, potential complications include allergic reactions, rare, local skin discoloration, hyperpigmentation, which usually fades but can persist, thrombophlebitis in the treated vein, rarely DVT, and even skin necrosis if the solution leaks outside the vein. Newer techniques are also emerging, like using foam sclerotherapy or combining sclerotherapy with mechanical devices or even special medical adhesives like cyanoacrylate glue to close the veins non-thermally.
What about heat-based treatments?
Yes, endovenous ablation using either laser energy, endovenous laser ablation, or EVLT, or radiofrequency energy, radiofrequency ablation, or RFA, has become extremely popular, especially for treating reflux in the main superficial veins, the GSV or SSV.
Why is it so popular?
The big advantages are that it's minimally invasive, usually done under local anesthesia in an office setting, and generally associated with a much quicker recovery and less post-procedure pain compared to traditional surgical stripping. Long-term studies show it's very effective at closing the vein durably, with results comparable to open surgery in terms of preventing varicose vein recurrence and improving symptoms.
How does it work?
Under ultrasound guidance, a small needle is used to access the target vein, usually in the thigh or calf. A thin sheath is placed, and then the laser fiber or RFA catheter is threaded up inside the vein, positioned just below the junction with the deep system. Then, a large volume of dilute local anesthetic, called tumescent anesthetic, is injected all around the vein. This numbs the area, protects surrounding tissues from the heat, and squeezes the vein down onto the catheter. The laser or RFA device is then activated, delivering heat to the vein wall as the catheter is slowly withdrawn, sealing the vein shut from the inside.
Risks with ablation?
Risks are generally low, but can include DVT, rarely, bruising, temporary numbness, or nerve irritation, especially near the ankle if treating the SSV, and skin burns, very rare with proper technique.
Is traditional surgery still done? Vein stripping?
Saphenous vein ligation and stripping may still be the preferred therapy in some cases, particularly for patients with extremely large diameter GSVs, maybe over 2 centimeters.
How is that performed?
It usually involves a small incision in the groin to tie off the GSV at its junction with the deep vein, and another small incision lower down, often below the knee. The vein is then removed, stripped, using a special tool passed through the vein.
Complications?
Complications can include bruising, hematoma, nerve injury, especially to the saphenous nerve causing numbness, infection, DVT, and sometimes fluid collections called lymphocytes in the groin. However, when done well, it's associated with a lower rate of varicose vein recurrence long term compared to sclerotherapy alone, and good quality of life improvement.
What about those lumpy veins that aren't the main saphenous veins?
For those larger branch varicosities, a technique called stab avulsion phlebectomy is often used, frequently in conjunction with ablation or stripping of the main refluxing vein.
How does that work?
Tiny incisions, maybe just 2 millimeters, are made directly over the bulging varicose veins. Using small hooks or instruments, the vein segment is gently pulled out through the incision and removed, avulsed. Usually no stitches are needed, just small adhesive strips. Bleeding is easily controlled with leg elevation, pressure, and often using that tumescent anesthesia beforehand helps minimize bleeding too.
So let's bring this together. What does this all mean? For someone actually living with chronic venous insufficiency, CVI, this clearly sounds like a condition with a really profound, often debilitating impact on their life.
You're absolutely right. CVI affects a huge number of people, estimated around 600,000 in the U.S. alone suffering from the more severe forms like ulceration. And its impact is profound. Patients typically complain of that persistent leg fatigue, discomfort, aching, and heaviness.
And the signs.
The signs can range from visible varicose veins, skin pigmentation, that brownish discoloration, lipodermatosclerosis, the hardening and inflammation, and in the most severe stages, venous ulceration. But it's crucial to remember severe CVI isn't always associated with big, bulging varicose veins. The underlying deep or perforator vein issues can cause severe symptoms even without prominent surface veins.
And the impact on life.
Particularly with chronic venous ulcers, the negative impact is huge, physically, financially, psychologically. Quality of life studies report that a majority of patients with chronic leg ulcers experience severe pain, significantly decreased mobility, and nearly all find it negatively impacts their ability to work or function normally. The socioeconomic burden is staggering. Estimates suggest 2 million lost workdays per year and annual healthcare costs easily exceeding $1 billion in the U.S. just for venous ulcer care.
What's the underlying cause again, primary versus secondary?
Right. We categorize it as primary CVI when it results from intrinsic abnormalities or weaknesses in the vein wall or valves themselves, often genetic. Secondary CVI, also often called post-thrombotic syndrome or PTS, occurs as a direct consequence of damage caused by a previous deep vein thrombosis, DVT.
And the symptoms relate to?
The signs and symptoms, the swelling, pain, skin changes, ulcers can be attributed to venous reflux, that backward flow from leaky valves, venous obstruction, blockage, dysfunction of the calf muscle pump, or often a combination of these factors. Loss of vein wall elasticity also plays a role. In the majority of CVI patients, that valve reflex is considered the most important factor, although the most severe cases often involve an element of obstruction as well. We touched on evaluation earlier. Historically, those invasive studies measuring ambulatory venous pressure, AVP, and venous reflux time, VRT, were key.
Right, the needle in the foot pain.
Exactly. Measuring the pressure drop during exercise, AVP, and how quickly it recovered, VRT. A high AVP meant high venous pressure, correlating with severity. A short VRT, less than 20 seconds, indicated significant reflux. You could even use a tourniquet on the side to try and distinguish between superficial and deep system reflux.
But limited.
Limited, because they only measured overall function, couldn't pinpoint the exact location of the problem valves, or really assess the calf pump effectively. Non-invasive plethysmography techniques like photoplethysmography, PPG, using infrared light to estimate VRT, or air plethysmography, APG, using an air cuff to measure volume changes and estimate reflux and pump function were developed. APG was theoretically attractive for quantifying things like reflux, venous filling index, pump function, ejection fraction, and residual volume, potentially guiding surgery, but never became widely adopted clinically.
Which brings us back to
Venous duplex ultrasound, DUS. If we connect this to the bigger picture, DUS is truly the game changer here. It absolutely has become the gold standard for evaluating venous function in CVI, largely replacing those older venographic and plethysmographic techniques.
Why is it so much better?
Its principal advantage is the ability to evaluate reflux in individual venous segments. You could look specifically at the common femoral vein, the popliteal, the posterior tibial, the GSV, the SSV, even perforator veins. This allows for highly targeted treatment aimed at the specific abnormal areas causing the problem.
How is the DUS reflex study done?
It needs to be done properly to be valid. Usually the patient is standing, but with the leg being examined relaxed, not bearing weight. Pneumatic cuffs are often placed around the thigh, calf, and sometimes the foot. The ultrasound probe is positioned just above the cuff.
And then
The cuff is rapidly inflated to a standard pressure for a few seconds, which squeezes blood upwards and then is rapidly deflated. The ultrasound watches for backward flow, reflux, occurring immediately after deflation.
what's considered abnormal reflux?
The presence of reflux lasting longer than 0.5 seconds is generally considered abnormal. Normal venous valves should snap shut much quicker than that, within half a second. A comprehensive exam checks all the key deep and superficial veins for reflux using this method.
So let's talk management. What's the main way CVI is managed day to day, and how does that approach actually work to help people?
The absolute cornerstone, the mainstay of CVI management, particularly for controlling symptoms and healing ulcers, is compression therapy.
Compression, compression, compression.
It really is key, and it can be achieved using various techniques. The most common are graduated elastic compression stockings. But there are also paste gauze boots, like the UNA's boot, multi-layer elastic wrap systems, and even intermittent pneumatic compression IPC devices used at home. Interestingly, non-elastic compression bandages generally achieve higher and more sustained compression levels than purely elastic ones.
How exactly does compression help? What's the mechanism?
The exact mechanisms are still being fully understood, but we have a good idea. It's likely a combination of things. Compression improves the hemodynamics, the blood flow, in the skin's microcirculation. It increases the pressure in the subcutaneous tissue, which helps counteract the forces pushing fluid out of the capillaries, thus reducing edema.
Less swelling means better skin health.
Exactly. By reducing edema, the diffusion of oxygen and other essential nutrients to the skin cells improves. Studies have even shown quantifiable differences in ulcer healing environments with compression, like decreases in certain enzymes that break down tissue and inflammatory markers. It basically helps normalize the environment in the skin and subcutaneous tissue.
What needs to happen before starting compression?
Education is paramount. Patients must understand this is a chronic disease, and compliance with compression is essential for healing and, just as importantly, preventing recurrence. A definitive diagnosis of venous ulceration needs to be made, ruling out other causes like arterial disease, Checking pulses is crucial. Diabetes or vasculitis. Coexisting medical conditions that affect healing, like diabetes, heart failure, malnutrition, or immunosuppression, need to be optimized.
Tell us more about the stockings.
Graduated elastic compression stockings are widely available, come in different materials, strengths, measured in MEMG, example 20, 30, 30, 40, 40, 50, and lengths. They can be custom-made or prefabricated off the shelf.
Do they really work for ulcers?
The benefits are very well documented. Numerous studies show high rates of ulcer healing with consistent use of adequate compression. Often 30-40 mmHg below knee is usually sufficient. And crucially, ulcer recurrence rates are dramatically lower in patients who remain compliant with wearing their stockings long-term compared to those who don't. We're talking maybe 30% recurrence at 5 years versus nearly 100% recurrence much sooner in non-compliant patients. Mean healing time is often around 5 months, but can vary widely.
Does it help quality of life, too?
Definitely. Compression therapy consistently improves quality of life scores in CVI patients by reducing symptoms like swelling, pain, aching, heaviness, improving activity tolerance, and even helping with associated issues like depression or sleep disturbance.
But compliance is tough, you said.
It's the Achilles heel. Compliance is crucial, but incredibly challenging. Patients might find the stockings uncomfortable, painful near an ulcer, hot, difficult to put on, especially if they're older or have arthritis, or they dislike the appearance.
How can compliance be improved?
Several strategies. Instruct patients to put them on first thing in the morning, before their legs swell. Start gradually, maybe wearing them for a few hours and increasing the time. Sometimes starting with a lower compression level and working up helps. There are many commercial aids, silk liner socks to help slide them on, adjustable wrap devices with Velcro closures, zippered stockings, metal frames called fitting aids or donners. But even with all these aids, many patients struggle to remain compliant long-term.
What about the Una's boot? Is that still used?
Yes, the Una's boot is a classic treatment developed over a century ago, but still used. It's typically a 3-layer dressing. The inner layer is gauze impregnated with a paste containing zinc oxide, calamine, glycerin. It's soothing and provides medication. This is applied with graded compression. Then a layer of gauze and an outer elastic wrap.
How does it work?
It dries to form a semi-rigid cast or boot, which provides sustained compression and resists edema formation very effectively. It's usually changed weekly or sooner if there's a lot of drainage.
Advantages and disadvantages.
Advantages. Minimal patient involvement once it's applied correctly by a professional. Provides continuous compression and topical treatment. Disadvantages. Can be bulky, messy, uncomfortable, itchy. The ulcer can't be inspected between changes. The quality of compression depends heavily on the skill of the applicator. Potential for contact dermatitis.
Is it effective?
Yes. Studies show good healing rates, often superior to simple dressings. A major Cochrane review confirmed compression increases healing rates, and specifically found that multi-component systems, like Una's boots or multi-layer wraps, are more effective than single-component systems. And elastic multi-component systems might be slightly better still.
Any other compression dressings?
Yes, various multi-layered elastic wrap systems are available. They often maintain compression longer than a simple elastic bandage, distribute pressure more evenly, and absorb exudate better. Again, effectiveness depends on proper application technique. There are also newer legging orthosis devices, adjustable wraps with Velcro straps that patients can potentially apply themselves daily, providing compression similar to an Una's boot, but with more flexibility.
What about skin substitutes for ulcers?
This is an area of active development. Skin substitutes, bioengineered products that mimic skin structure, are being studied. They range from simple acellular scaffolds to partial or fully living constructs.
How do they help?
The exact mechanism isn't fully clear, but they likely work by providing a scaffold for the patient's own cells to grow into, and by delivering growth factors and cytokines that are important for stimulating the wound healing process.
Is there an example?
Apligraf is one commercially available example. It's a bilayered living skin construct with both epidermal keratinocyte and dermal fibroblast layers. It comes as a disc that's placed directly onto the prepared ulcer bed. It's costly, but studies have shown it can significantly improve healing rates and reduce the time to complete ulcer closure compared to compression alone, especially for large or long-standing ulcers that have failed other treatments. It doesn't seem to cause rejection. #tag surgical interventional treatment of chronic venous insufficiency.
Okay, so compression is king for non-operative care. But when do doctors need to intervene more aggressively? What surgical or interventional options exist for CVI when conservative methods just aren't cutting it?
Right. When conservative therapy, especially compression, fails to heal an ulcer or manage severe symptoms, more invasive approaches are considered. One area that received attention was ligating or closing off incompetent perforating veins.
Those connectors between superficial and deep?
Exactly. They were implicated in causing ulcers, especially around the ankle. The classic open surgical approach, the Linton procedure from the 1930s, had very high rates of wound complications and is pretty much abandoned now.
So, minimally invasive options.
Yes, subfacial endoscopic perforator vein surgery, or SEPS, evolved. Using endoscopic equipment inserted through small incisions away from the ulcerated area, surgeons could go under the fascia, visualize the incompetent perforators using CO2 insufflation, and clip or divide them.
Did SEPS work well?
Its role has been controversial, especially as a standalone procedure. Some registries showed good ulcer healing rates, particularly when combined with superficial vein surgery, but recurrence rates were similar to compression therapy alone. A large European trial actually showed no added benefit from SEPS when added to superficial venous surgery and compression. So the technique seems to have fallen out of favor in many places, often replaced by ultrasound-guided sclerotherapy for incompetent perforators, which is simpler.
What about surgery on the main superficial veins themselves, like we discussed for varicose veins? Does that help ulcers?
Yes, this is now much more widely accepted. Superficial venous surgery, or ablation, definitely has a role in treating venous ulcers in addition to compression therapy, specifically for patients who have documented superficial venous insufficiency contributing to their CVI.
What's the evidence?
A landmark UK trial, the SCHWARTZ trial, randomly assigned patients with venous ulcers and superficial reflux to either compression alone or compression, plus superficial venous surgery. The key finding was that while surgery didn't significantly speed up the initial ulcer healing, it dramatically reduced the rate of ulcer recurrence over 4 years.
So it prevents them coming back.
Exactly. Based on this strong evidence, it's now considered very reasonable, even recommended, to offer ablation, like laser or RFA or surgical removal of the GSV or SSV, in addition to lifelong compression therapy for patients who have abnormal saphenous veins contributing to their severe CVI or ulceration.
What about fixing the deep veins surgically? Valves again?
Deep venous valvular reconstruction was explored, especially for patients with combined superficial and deep valve incompetence. The theory was that fixing the deep valves would further improve outcomes. Various complex techniques were tried, directly repairing existing valves, valvuloplasty, transplanting vein segments with healthy valves from the arm, transposing an incompetent vein onto an adjacent competent one, even using cryopreserved vein segments.
Did any of these work?
Some centers reported reasonable short-term success, maybe 60–80% patency and competency for direct valve repairs. However, long-term outcomes were often disappointing, especially for ulcer patients with high rates of recurrent reflux and ulceration. Transplanted segments often failed over time due to valve incompetence or scarring. Venous transposition results were similar. Because of these challenges and limited long-term success, these complex, deep vein reconstructions are rarely performed today for CVI.
Anything else on the horizon? Stents.
Yes, there's significant growing interest in the role of venous stenting in CVI treatment. This focuses mainly on treating stenotic lesions, narrowings, or blockages, often found in the large iliac veins in the pelvis. These lesions, best documented with intravascular ultrasound, IVUS, are reported in surprisingly high percentage of patients with severe CVI symptoms, like edema, lipodermatosclerosis, or ulceration.
Can stents be placed easily? Do they stay open?
The percutaneous placement of stents in the iliac veins is technically feasible with very high success rates, nearly 100%. And importantly, early data suggests excellent patency rates, meaning the stents stay open out to 4 years or more.
What effects are seen?
Retrospective case series, looking back at patients who had iliac vein stenting, suggest quite favorable effects on ulcer healing, improvement in CVI symptoms like pain and swelling, and better quality of life scores.
So, is stenting the future?
It's certainly a very active area of investigation. The exact role of venous stenting, especially as an independent procedure versus combined with other treatments, is still being defined through ongoing research and trials. But it holds considerable promise as another tool in the armamentarium for treating select patients with severe CVI, particularly those with documented proximal obstruction.
Okay, let's move on now to another type of chronic swelling, one that's often confused with venous issues but is quite distinct. Lymphedema. How is it different and why does it happen?
Right, lymphedema is different. It's extremity swelling that results specifically from a problem with the lymphatic transport system. There's a reduction in the body's ability to drain lymph fluid, that protein-rich fluid carrying waste and immune cells, from the interstitial space, the tissue between cells. So this fluid accumulates.
What causes that reduction in transport?
It can be due to anatomical problems like the lymphatic vessels being underdeveloped, hypoplasia, or functional issues like the lymphatic system just not working efficiently, or maybe absence or malfunction of lymphatic valves, which also exist.
Is it always something you're born with?
No, we classify it based on origin. Primary lymphedema is the type related to congenital or developmental abnormalities of the lymphatic system. It can be present right at birth. That's congenital lymphedema, sometimes associated with specific genetic syndromes like Turner syndrome or Milroy syndrome. The most common form of primary lymphedema, though, making up over 90% of primary cases, is lymphedema precox. This typically starts during childhood or the teenage years. It's far more common in women, maybe a 10.1 ratio, and usually involves the foot and calf initially. Then there's a rarer form, lymphedema tarda, where the swelling onset is much later, after age 35.
What about lymphedema caused by something else?
That's secondary lymphedema, and it's actually far more common overall than primary lymphedema. It develops because something obstructs or disrupts previously normal lymphatic pathways.
Like what? What's the most common cause here?
In the US and many developed countries, the most common cause is axillary lymph node dissection, usually done as part of breast cancer treatment. Removing those nodes disrupts drainage from the arm, leading to arm lymphedema.
What else can cause secondary lymphedema?
Other causes include radiation therapy, which can scar lymphatics, significant trauma, recurrent infections that damage lymph vessels, and malignancy itself. Tumors can grow and physically block lymphatic channels.
Are there other major causes globally?
Yes, worldwide, the most common cause by far is filariasis. This is a parasitic infection spread by mosquitoes, caused by worms like Wuchereria bancrofti that live in and obstruct the lymphatic system. Another significant cause in certain regions is podoconiosis, related to chronic exposure to minerals in volcanic soil in barefoot populations, leading to severe lower leg lymphedema. ## clinical diagnosis. Now, interestingly, for most patients, the diagnosis of lymphedema can actually be made based on the patient's history and a careful physical examination alone.
What do patients usually report?
They commonly complain of a feeling of heaviness and fatigue in the affected limb. The limb size typically increases throughout the day, and while it might decrease slightly overnight with elevation, usually never completely returns to normal size, unlike simple edema from other causes.
Are there classic physical signs?
Yes, there are some classic signs. In the lower extremity, the swelling typically involves the dorsum, the top of the foot, and the toes often take on a squared-off, sausage-like appearance. A key sign is stemmer sign. The inability to pinch or tent the skin at the base of the second toe is highly suggestive of lymphedema. In advanced, long-standing cases, the skin can become very thick and hardened, a condition called hyperkeratosis, and sometimes lymph fluid can actually weep from small vesicles on the skin surface.
You mentioned infection risk earlier.
Yes, recurrent cellulitis is a very common and serious complication. Patients with lymphedema are highly susceptible to bacterial skin infections in the affected limb. This is thought to be due to microscopic breaks in the skin barrier caused by the chronic swelling, or sometimes related to unrecognized or untreated fungal infections like tinea pedis, athlete's foot, providing an entry point for bacteria.
And infection makes it worse.
It creates a vicious cycle. Each episode of cellulitis further damages the already compromised lymphatic vessels, which worsens the edema, which in turn increases the risk for future infections. Clinically, cellulitis can range from subtle redness and increased swelling to a rapidly progressing severe soft tissue infection with fever and systemic illness.
How do you tell lymphedema apart from other causes of leg swelling?
In mild early cases, it can sometimes be difficult to distinguish from venous insufficiency just based on appearance. However, as we discussed, advanced venous insufficiency usually has characteristic features like the brown pigmentation and skin hardening concentrated in the gaiter area, maybe visible varicose veins or active ulcers. Lymphedema swelling tends to be more diffuse and involves the foot and toes more prominently early on. Bilateral pitting edema swelling that leaves an indent when pressed, affecting both legs equally, is more typical of systemic causes like congestive heart failure, kidney failure, or low protein states, which need to be ruled out. ## radiologic diagnosis, submitted clinical use.
So if the clinical signs are often quite distinctive, how much do doctors actually rely on imaging specifically for diagnosing lymphedema? Is it common?
That's a key point. While duplex ultrasound is often done to rule out any contributing venous problems like DVT or reflux, the specific imaging tests for the lymphatic system itself have fairly limited use in routine clinical practice.
Why is that?
They tend to be invasive or tedious to perform, and frankly, the results rarely change the fundamental management plan for the patient. Because of this, most physicians rely primarily on the patient's history and the physical examination findings alone to make the diagnosis of lymphedema.
What are those specific lymphatic imaging tests, even if uncommon?
The most commonly used one nowadays, though still not routine, is lymphoscintigraphy.
How does that work?
It involves injecting a very small amount of a radio-labeled substance, usually technetium-99 sulfur colloid, just under the skin between the toes or fingers of the affected limb. Then, a special gamma camera monitors how this tracer travels through the lymphatic channels over time, visualizing the major lymphatics and the lymph nodes they drain into.
What does a normal scan look like versus lymphedema?
Normally, you'd expect to see the tracer reach the lymph nodes in the groin or armpit fairly quickly, within maybe 15 to 60 minutes, and see uptake in deeper nodes within a few hours. In lymphedema, you might see various abnormal patterns, significantly delayed or even absent transport of the tracer to the regional lymph nodes, evidence of tracers spreading out into skin collaterals because the main channels are blocked, dermal backflow, or maybe localized areas of reduced uptake, indicating damage from prior surgery or radiation.
Is there another test? Lymphangiography.
Lymphangiography is the older technique, and it's even less commonly used now. It's quite invasive.
How's it done?
First, a blue dye is injected into the skin to try and visualize a superficial lymphatic vessel. Then, a small incision is made over that vessel, and a tiny needle, like a 27 or a 30 gauge, is carefully cannulated directly into the lymphatic. Then, an oil-based contrast dye is injected very slowly over several hours. Finally, traditional X-rays are taken to visualize the lymphatic channels and nodes filled with the oil dye.
Why would anyone do that now?
It's really reserved for very specific situations, perhaps in patients who have lymphatic leaks or fistulas, or maybe if complex microvascular reconstructive surgery is being contemplated, where detailed anatomical mapping is needed. But for standard diagnosis, it's largely been replaced by lymphoscintigraphy or just clinical evaluation.
Okay, so since there's currently no cure for lymphedema, what are the primary goals of treatment? How is it managed long-term to help people live with it better?
That's the most important message for patients up front. Understanding that lymphedema is a chronic condition with no current cure. Therefore, the primary goals of treatment are really twofold. First, to minimize the swelling as much as possible, and second, crucially, to prevent recurrent infections like cellulitis. By effectively controlling the chronic limb swelling, we aim to improve the patient's symptoms, the discomfort, heaviness, tightness, and potentially reduce the long-term progression of tissue changes.
What are the key therapies used?
The cornerstones of management revolve around compression and lymphatic drainage techniques. Compression garments, specifically graduated compression stockings or sleeves, are widely used and essential.
How do they help in lymphedema?
They work by providing external support to reduce the accumulation of lymph fluid while the limb is dependent, hanging down. Consistent daily wear is associated with maintaining reduced limb circumference long term. They may also help protect the tissues from the effects of chronically elevated internal pressure, which leads to skin and tissue thickening, and they offer some protection against minor trauma that could trigger cellulitis.
What kind of compression is needed?
The compression levels needed for lymphedema are often higher than for venous insufficiency, sometimes ranging from 30-40 mmHg up to 40-50 or even 50-60 mmHg, depending on severity. Stockings or sleeves can be custom made or prefabricated, come in various lengths, and need to be worn during waking hours. Like venous stockings, they lose elasticity over time and typically need replacing every 6 months or so. Compliance, again, is absolutely vital but can be challenging.
What about elevation?
Bed rest and ling elevation remain an important aspect, especially during acute flare-ups or infections and overnight. It helps drain fluid by gravity. However, keeping the limb elevated constantly isn't practical and significantly impacts quality of life, so it's an adjunct therapy, not the mainstay.
Are those pump devices used? IPC.
Yes, intermittent pneumatic compression therapy, IPC, using single chamber or more effectively multi-chamber pumps can temporarily reduce edema. These sleeves inflate sequentially up the limb, helping to milk the fluid out. They serve as another adjunct to compression garments. The pump effectively reduces limb volume while it's being used, but compression stockings are necessary to maintain that reduction once the patient is upright and active again. IPC is typically used at home for several hours a day, usually while the patient is resting.
What about massage?
Specialized lymphatic massage, often called manual lymphatic drainage, or MLD, is a key component of what's known as complex decongestive therapy, CDT. This involves gentle, specific massage techniques aimed at stimulating lymphatic flow and redirecting fluid away from congested areas towards functioning lymph nodes. When performed by a trained therapist, MLD, usually combined with compression bandaging initially and then garments, is associated with significant long-term edema reduction and fewer episodes of infection.
And managing infection risk.
Antibiotic therapy is critical. As we said, patients are at high risk for cellulitis. Prompt treatment at the very first sign or symptom, like redness, warmth, increased pain, or swelling, fever, is essential. Aggressive antibiotic therapy, usually targeting streptococcus bacteria like penicillin or cephalosporin, along with elevation and compression, is recommended for at least 5 days, sometimes longer.
What if someone gets infections frequently?
For patients suffering from recurrent cellulitis, for example, 2 or more episodes per year, long-term suppressive antibiotic therapy is often effective. Options include monthly intramuscular injections of long-acting benzathine penicillin or daily oral antibiotics like low-dose penicillin V or erythromycin. Meticulous skin care and prompt treatment of any fungal infections are also crucial for prevention.
Is surgery ever an option for lymphedema?
Surgery for lymphedema has a long and varied history, but it's generally not considered a primary treatment and is reserved for very specific, often severe, cases where conservative measures have failed. It's important to state that no surgical procedure cures lymphedema, and long-term follow-up data from many techniques are limited. Plus, there's always a risk that surgery could further damage lymphatic channels and potentially worsen the edema.
What types of surgery are there?
Broadly, there are excisional procedures, like the Charles procedure, largely historical, or liposuction for lymphedema, more common now for fatty deposition, which aim to debulk or remove the excess swollen tissue, primarily improving limb size and shape, but not the underlying lymphatic drainage. Then there are microsurgical procedures that attempt to physiologically improve drainage, like creating lymphatic bypasses, connecting working lymphatics around a blockage, or lymphatic aphonosis anastomosis, connecting lymphatic vessels directly into small veins. These are technically demanding procedures with variable long-term success rates, still largely considered investigational in many centers. #@checkoutro.
Wow. Okay. Today, we've really journeyed through the incredibly complex and dynamic world of venous and lymphatic diseases. We went from the intricate anatomy of veins, the vital role of those tiny valves,
Yeah?
to the significant impact of conditions like DVT, those common varicose veins, the chronicity of venous insufficiency, and that often misunderstood lymphedema. We explored the advancements in diagnosis, too, from those older clinical tests to the amazing precision of duplex ultrasound.
Yeah, the imaging has come a long way.
And the array of treatment options is pretty vast now. 2 sophisticated blood thinners, cutting-edge clot-busting techniques, comprehensive compression strategies, and even surgical interventions when really needed.
I think what truly stands out really is the critical balance within these systems. They're often overlooked until they cause problems, but disruptions can have such profound, far-reaching effects on a person's health and quality of life.
Yeah.
And the consistent theme, I think, running through everything we discuss is the importance of early, accurate detection, and then applying these diverse, often very personalized approaches to manage the conditions. The goal is always improving quality of life for you, our listener, and preventing those severe long-term complications.
Absolutely. We really hope this deep dive has given you a thorough but also engaging understanding. Hopefully you had some of those aha moments and feel more confident and well-informed about these really essential but often quite misunderstood aspects of health.
Definitely. And maybe it leaves us with a thought. Given the chronic, often progressive nature of many of these conditions, like CVI and lymphedema, and knowing how absolutely critical patient compliance is for long-term management, what societal changes or maybe healthcare system adjustments might be needed to better support individuals living with these conditions day in, day out for the long haul?
That's a big question. How can individual empowerment, giving people the tools and support they need, combined with continued medical innovation, how can that further bridge the gap in managing these really complex, often lifelong conditions?
Something to think about.
Definitely something to think about. Join us next time for another deep dive into your sources, uncovering more fascinating insights. Until then, keep that curiosity flowing.